Well, welcome everybody. Just to give you a little bit of information on me, I'm actually born in Richmond, raised in Richmond, and as luck would have it, my father is a gastroenterologist as well. I resisted it greatly, but I just succumbed to the reality. I'm also very interested in gastroenterology, it just so happened. And how I actually came upon this opportunity in particular is that I have an interest in the esophagogastric junction in particular. I actually kind of came to this through a problem kind of in the proper orientation of how food goes down. A disease called achalasia is when your lower esophageal sphincter is too tight. GERD is sort of the opposite, I could think, when things are a little bit too loose. So I figured, you know, I spent a lot of time getting to know the esophagogastric junction from one end, and it just made sense that that I pay attention from the other, because it is a lot more common, as it turns out, to have reflux disease. So that's where I'm coming from. So again, welcome, and to give you a little bit of roadmap of where I'm going to take you. So we'll start off with the causes of GERD. Going through some of the symptoms. Some you'll be familiar with, others might be new to you. Talk about a couple of the related diseases that I see on a regular basis. And then just going through sort of some things you're probably familiar with and some you might not be, as far as diet and behavioral therapy, things you can do to help decrease your symptoms. And then we'll talk about pharmacologic medical therapy, so drugs that are commonly used for reflux. And then I'm going to kick things off to Dr. Smith to talk a little bit about surgical therapy. So hopefully have a nice round introduction to things, and he'll repeat a couple of the things that I'm talking about, but reinforcement is good, so don't worry if you hear a couple things twice. Okay, so what is GERD? So GERD is any pathology that comes from reflux of stomach contents into your esophagus. Okay, so that ranges quite a bit, and I'll go over some of the diseases we see. So is reflux the same thing as GERD? So yes, but. So usually when people are saying reflux, they're thinking more acid reflux, but as it happens, acid can reflux up. There are other things that can reflux up too. People can have an alkaline reflux from reflux of bile, which can be just as irritating. So they're synonyms, but a little bit different. So what is heartburn? So heartburn is what 20% of Americans experience. So after you eat, having some burning in the middle of your chest, what we refer to as kind of the epigastrum and middle of your chest, just kind of a gnawing, burning sensation that hits you after a meal. But interestingly, so can you have GERD without heartburn? So absolutely. Some people have large volumes of reflux from their stomach with no heartburn whatsoever. They actually can just have frank regurgitation. So honestly, so the stomach contents just coming up, and some people will have that sensation, swallow things back down, but some people will literally regurgitate, and that is not one of the more common symptoms to frankly regurgitate, but a lot of people have that sensation of things coming up in the back of their throat and forcing them back down with the swallow, especially at night. It's very, very common. Couple of ways. So what causes gastroesophageal reflux disease? So, you know, there are books written about this as far as the causes, and you know, kind of the better our testing has gotten and the more sophisticated our thinking has gotten about it, you could say there are 12 mechanisms of reflux. But as it happens, I think these are the easiest to understand, and they just make good sense. Kind of all the other causes can fit in with these. So the first is relaxation of the lower esophageal sphincter, and I'm going to show you a little bit on a little bit of anatomy, and we can get into that a little bit more. So basically, what you can think of is either a weakening of a muscle or that muscle relaxing inappropriately. Okay, and that's actually, as we have come to realize, the most common cause of reflux is that sphincter, for one reason or another, gets a signal to relax when it probably shouldn't. So the second cause I'd like to talk about is hiatal hernia. So it's when part of the stomach herniates up into the chest, and as we'll see, that basically creates a big mess, unfortunately. We've kind of gone back and forth in medicine about how significant hiatal hernias are, and we can talk about that in a second once we get there. But so the third component to what causes GERD is increased intra-abdominal pressure. I think best example of this is we have a lot of women in the audience, some of whom have likely been pregnant at one point or another, and pregnancy is super common. Well over 50% of pregnant women get rip-roaring reflux during pregnancy, and it's a combination of things, but it's largely an increase in intra-abdominal pressure. There's less space in there, and the space that is occupied is under some higher pressure. So here's a little bit of anatomy. I think it's a good way to explain it, and this is how in medicine we think about it as well. So we're born with a really sophisticated barrier system for reflux. We're not designed to reflux. It's something that we have a lot of mechanisms in place to prevent it. So there are kind of two sides of the coin. There's inside the esophagus, you have those mechanisms, and then you have mechanisms on the outside of the esophagus, okay? So inside the esophagus, so things are coming down through this orientation. So inside, we have this character, this lower esophageal sphincter, okay? So it's a thickening of muscle. You can think of it just like the one at your bottom, but it's not under your control at all, okay? So that is the first or one of the early barriers inside the esophagus. Another one is actually that's not really represented very well on this slide is that right here in the stomach, there are these little clasping fibers, which is another little, basically muscular barrier to reflux. And it happens right before this little flap valve, this gastroesophageal flap valve. So that's three things that are designed to help prevent reflux. And those are kind of all intrinsic to the esophagus and the stomach. They're all in the walls of the esophagus and the stomach. Okay? Now, the extrinsic parts, so the part outside the esophagus that's designed to help prevent reflux, is largely the diaphragm. So this is your breathing muscle here, your diaphragm, so that allows you to take a nice deep breath. And what it does is it basically, as you're breathing and just in coordination when you're not knowing it, it exerts external pressure right at the bottom of your esophagus as well. And it kind of, the way I think about it is it lengthens your lower esophageal sphincter in some ways. I mean, when you kind of think about it, I'll give you kind of an analogy of all this, but you can see that we're actually built to have there are quite a few mechanisms in place to prevent us from having reflux, and we still have it. So it is not an easy problem, and when people do have reflux, which again is very common, I think about it as there's a breakdown somewhere along this chain. Sometimes with everything, it's just and it can be sometimes tough to tell, and that's another reason why this is a great field for me. It's very interesting, and it's a tough problem. So, talking about lower esophageal sphincter relaxation. So this is the most common scenario. This is what your cup of coffee does. This is what peppermint ice cream does, and this is how I'd like to just kind of. I was trying to come up with a good analogy, and this is the best I have. Okay, so bear with me. So you're coffee. Okay, you're have in your mind that you're coffee. You're going to embody coffee. So you were, born in Colombia, beautiful fields, and you were stripped from your home. You're taken away, ground up, boiled, and ingested. You have an axe to grind. You're not a happy camper. Yes, you were delicious, but you're not a happy camper. So what are you going to do? You are going to exact revenge. Okay? And how are you going to do it? You're going to do it through relaxation of this lower esophageal sphincter. So that's how coffee in particular will hurt you. As far as the next most common mechanism, just going over a couple of the, it's not just coffee, as some of you might suspect. So acidic foods, things like tomato sauce. Tomato sauce tends to be a culprit, unfortunately. Caffeine, chocolate, peppermint, and these aren't universal. And different people will have different foods that are their trigger foods, it's just very, very common. So the other component to transient relaxation of the sphincter is weakness. So there are things that make this muscle weaker. Smoking is one of them, as far as common things being common. Alcohol exerts quite a bit of stress on the muscle, and stress. When you are stressed, when you have, it's crazy to think that things going on in your head don't affect the rest of your body. They absolutely do. You have a lot of different physiology going on when you're in a stressful time in your life, and it clearly has an impact.
So doctor, that muscle weakness, is it reversible or reversible?
So we don't really know, to tell you the truth, and I haven't seen a study that's demonstrated reversibility of the weakness. That's a great question. So hiatal hernia. So this is what hiatal hernia is. This is another very, very common, this is probably one of the most common structural problems that I see doing upper endoscopy. So looking in people's stomachs with a little camera at the end of a long tube. And so there are two different types. It's not super important for these purposes, but you can imagine. So here is where your diaphragm was. That's where it started. Now it's down here. You have a piece of your stomach that's herniated up through there, and you can imagine. So you kind of, and in some situations, people will functionally end up with two stomachs, except one stomach isn't under hardly any control from that gastroesophageal junction mechanism. So it's you can very easily have fluid that just hangs out in here and is really not restricted by very much at all. It can very easily reflux up into your esophagus because instead of 5 barriers, it's got 1 barrier to combat with. Another type of hernia is this one right here. It's even more of your stomach herniating up into your chest, they both cause their fair share of problems, to be sure. So increased intra-abdominal pressure, we talked about this, just little parallel bellies. Obesity is a huge problem in America, and it's a huge contributor to reflux. It's one of those things that actually losing weight has been shown to help considerably, and the way it does is it decreases the pressure in your gut. At least that's what we think is happening. We know for sure your pressure in your stomach. It's a direct relationship. It's per unit of what we call BMI, so body mass index. It's just a measure of how thick you are per how tall you are, and as that goes up, you have a direct increase in the pressure in your stomach. And there's no way it's that simple, to be honest with you. There are other things going on, but we at least have that in our pocket that's contributory, just more of a pressure gradient. Because that's all these are. A lot of what these mechanisms are valves. At least you have one that's certainly a valve. And if your pressure on one side of a valve exceeds that on the other, things can overcome the valve and reflux up. So more well-known symptoms that you guys have surely come across again is the heartburn, that burning sensation, and regurgitation, just both in the form of kind of having that sense when you wake up in the morning of just a bad something in the back of your mouth, a bitter taste, again that sensation of things coming up without you vomiting. You're not retching. You're not vomiting. It's an involuntary thing that just comes up and bites you. Lesser known symptoms that we're coming to appreciate more and more. And, to tell you the truth, the jury is a little bit out on really how common these symptoms are. We might be going towards one a little bit towards the nth end of the spectrum, saying that anyone with a chronic cough has reflux as the reason behind their chronic cough. I don't think it's going to be that simple, but chronic cough is certainly, reflux is a common cause, we believe, right now. Asthma, sort of in the same vein. If you continually have things refluxing from your esophagus up into your mouth and they go down the wrong pipe, that is certainly a source of chronic inflammation and asthma and inflammation. So shortness of breath, same process, can give you a bad, what we call aspiration pneumonitis or chemical pneumonitis in your lungs. And enough pneumonitis is going to result in a pneumonia. And pneumonia, sadly, is thankfully it's not as big a killer as it once was, but it's still a common cause of death in the hospital. A bad pneumonia is something to be taken seriously. People, hoarseness, constantly cleaning your throat or clearing your throat. And dental problems, erosion of the enamel on your teeth. It's very common. It's acid, you know, and we kind of, whether you know it or not, if you're familiar with chemistry, the pH in your stomach is 2, so it is very acidic, and it can really cause some damage. This erodes the enamel right off your teeth. As far as things that I see commonly, so erosive esophagitis. So instead of a nice pristine mucosa in your esophagus, we see these big linear ulcerations and these are often painful. Sometimes though, people don't feel them hardly at all. It's wild, and they just again have their symptoms of regurgitation, whatnot, and they're not going away with simple therapy. And we go and we find this, and there's usually more than one reason why the reflux protective mechanisms have failed. Esophageal stricture, so just in response to your esophagus seeing acid after a spell of acid, it's very common, and people will come to me saying, I feel like things are hanging up in my chest. And this is something that's treatable. We can dilate it, and you can feel a good bit better, but oftentimes it'll happen again, and we come in and we'll dilate you again. Barrett's esophagus is something that has gotten more and more attention, and actually it's something, basically, if you think of reflux, it is on a continuum with esophageal cancer, unfortunately. So people that have reflux, about 1 in 10 people with reflux are going to have reflux esophagitis, like I showed you. So actual mucosal erosion. So you take that population, probably about 1 in 10 of those are going to have Barrett's esophagus when their esophagus heals. And it's what Barrett's esophagus is it's a protective mechanism, we think. Your esophagus mucosa is not designed to see acid. It doesn't like it. So if it keeps seeing acid, it takes the hint that, hey, maybe I'll be better off if I change to look more like the stomach. So it does. The problem is this is how cancer starts. Cells getting the idea to change what their job does. And so about, again, the numbers these are approximates, but for our purposes they work nicely. So you have 1 in 10 of people with erosive esophagitis having Barrett's, and about 1 in 10 of people with Barrett's, they don't necessarily get cancer, but they get the first step towards cancer, which is something called dysplasia. And it's something that thankfully we can take care of endoscopically, but that is the first step to cancer, make no mistake. And esophageal cancer, I don't know if any of you all had the unfortunate experience of a loved one having it, yourselves have one, or if you yourself have had esophageal cancer, but it's an awful cancer. It is an awful, awful cancer. It spreads very quickly, unfortunately, and its therapies are often limited. Usually we don't get folks in time. By the time they're having symptoms, sort of the cat's out of the bag sometimes, or a lot of times, actually. So as far as behavioral therapy, avoiding trigger foods is sort of what you intuitively do probably before you even tell your primary care doctor that you're having reflux. Weight loss is huge. It can make a substantial difference. We don't talk about it enough, but it really can. Smoking cessation goes without saying. Really, the more we look into disease, period, in particular cancer, but GERD is no exception, smoking is just not very good for you, as it turns out. Avoiding going to bed immediately after you eat is just simple a physics issue. If you have a full stomach, and you have any weakening or anything in the sphincter, a full stomach, things are under a little bit more pressure, they're more likely to reflux up. avoiding large meals that distend the stomach, and we think maybe distend and distort the anatomy in your distal esophagus, especially if you have something like a hiatal hernia, can help, eating smaller meals more frequently. And raising the head of your bed, even 6 to 8 inches, can actually make a big difference in some people. They actually, for a couple $100, you can get a nice wedge pillow that a lot of people swear by. So medical therapy for reflux. So just a brief run through. Antacids are very quick, very fast acting, but their effects are gone pretty quickly. You get quick relief, but they really are not sustaining. Basically, they are literally buffers. So they buffer the acid, and your stomach just kind of laughs and keeps going. It keeps making acid. So they really they do work fast, which is nice, but the relief is not long lasting or complete at all. Histamine receptor blockers have been around since the 70s, and they work actually pretty quickly in the grand scheme of things, about 5 to 10 minutes after taking them. These are the Zantacs and Tagaments of the world. They're over the counter, and a lot of people really do get on nearly complete relief from the reflux with a good dose of Zantac. We still use this medication all the time. It's very, very good medicine. But there is definitely a large number of people that they don't quite get complete relief. And the proton pump inhibitors are, from a pharmacologic standpoint and a physiology standpoint, the best drug we have. They work very well. They do what they're supposed to do. Relief generally is complete. The trick with them is that they're not a good pill to take when you're having heartburn. They're a little too slow to act. They take about a half an hour, 60 minutes, and so they're not going to be your medicine when you're having symptoms. They're a good medication that we have people take in the morning, 30 minutes before their first meal of the day. So things like prokinetic therapy and baclofen I'm not going to talk about. They're there. I just mention them because in certain situations they can be really helpful, but they're not for everyday reflux. So I can't talk about PPIs without talking about the news. So this is a very common visit to me these days, actually, with people who are on their pantoprazole or omeprazole, Prilosec, and Protonix, and they're very worried. They've seen news stories and things in the paper. They're saying, hey, these PPIs, these proton pump inhibitor medicines, they've got some bad stuff associated with them down the line. Just briefly going through them, I'll give you kind of my take on all these studies. Is all of the, fortunately, the media isn't always the best at giving you an idea how good the quality of data they're using actually is. Actually, and these are not bad studies. They're not stupid people conducting the studies. I don't mean that in the least. It's just whether or not all of these studies. The dementia study was prospective, so I looked at people 75 years and older and followed them for 9 years. It was a very, very good forward-viewing study, and generally a prospective study is a good one. But it was purely observational, okay? The chronic kidney disease was looking back on folks. The infectious colitis or Clostridium difficile colitis, it was, again, retrospective study. Same thing with intestinal bacterial overgrowth. Basically, when you're doing these observational studies, all you can really do is say there is an association between this and this. You can't really say there is any causation. And the example I use to sort of underlie this is that there were studies in the 40s and 50s that were association studies that said, oh, all the people that drink, they seem to got a lot of lung cancer. What's the link here? What's the link between lung cancer and drinking alcohol? Well, there's actually not much of a link. It just so happens that people that drink tend to smoke a fair amount. And there is a good relationship, a causal relationship we have found between smoking and lung cancer. So it's sort of a true, and we don't know if they're related as far as just about all of these. There was actually just a paper recently that with infectious colitis that said there is no relationship. They found no relationship, again, in an observational study between infectious colitis and PPI use. That said, bone health is something I do worry about. I think there is reasonable data that says people on long-term PPIs, we have to watch out for their bone health. And it has to do with calcium absorption, calcium handling. My older female patients, basically, if they need the medicine and it's helping them, I don't take them off the medicine necessarily. We just do it knowing that we're making a decision, and we handle it appropriately. We make sure that you're getting bone density scans and taking care of yourself. So,
when you say long term,
yes.
what is the long
Long-term
term?
PPI, that's a great question. I consider long-term, if you're on a medicine every day for longer than a year, that's kind of a long-term therapy. If we don't have a destination in mind, is a good way to think about it. If I'm not saying to you, take this medicine for 3 months and then stop, if I'm not saying that to you, I think of that as long-term. So why doesn't medical therapy always work? There are a lot of people that, I'm sure plenty in this room, who have been on all these medicines, and they still have symptoms. They still have reflux. They have not reflux symptoms, classic or not classic. And like I said, we're born with all these mechanisms to prevent this from happening. And over time, these barriers get overcome. And I'll go back to our coffee. So you're sitting in the stomach and you're unhappy. You're here to cause trouble. And so if you're getting ready for a fight, what would you rather fight? Would you rather fight 5 people all at once or 1 person at a time 5 times? I'd rather have a shot at 1 person, at a time 5 times in a row as opposed to 5 people at once. And that's essentially what's happening. That's the way I see it, is that when your gastroesophageal junction's intact, GERD doesn't stand a chance. It really doesn't. Especially if some people, they do just tend to reflux a little bit more, but really by and large it's controllable. If you've got a really intact gastroesophageal junction, it's 5 on 1. The coffee doesn't stand a chance. But if you have, whether it's recent things that you're born with, these things just being separated out a little bit more. If your lower esophageal sphincter is a little bit further away from these gastric sling fibers, things start separating and they don't act synergistically. And when they're not acting synergistically, it really does start to be on one-on-one fights, kind of literally, actually. And reflux can come right up and take things on one-on-one and beat you. And so with that, I'd like to turn things over to Clifford Smith. And as far as questions, if you have questions, I'll be happy to answer them. If you could save them for the end, I want to make sure Dr. Smith gets plenty of time to explain to you what you want to know and why you're all here. So here you are, sir.
Thank you. No, you're fine. Well, welcome to everybody. Hopefully after his lecture you'll decide that surgery is actually the right choice and not medicine. So, my hope is as we go through this, I'm going to touch on a few things that he touched on, just to sort of drive the point home, and then we'll talk mostly about the surgery side for this particular disease. I'll open just like he did, just to give you a little background on myself. I joined a practice here about a year ago. I retired from the Navy after 21 years last year and decided I had to change uniforms. So I decided to move to Richmond and been here for a year. I did a fellowship, minimally invasive fellowship back in like 2010, but I've been pretty much dealing with reflux disease ever since I got out of my residency in 2003. So it's an area of interest for me as well. And hopefully at the end of this discussion, you'll have a better appreciation for reflux disease as a whole and what we can offer you. Again, if you have questions, you can ask them in between. Otherwise, I'd just say wait till the end. We'll stick around and be happy to answer any questions that you have. All right. So again, as he talked, again, reiterating some things, lower esophageal sphincter disease, okay, it does contribute. Unfortunately, if you took 100% or 100 people, 40% of those people taking meds, unfortunately the meds do not work for. So that's sort of the target audience that we're looking for, okay? So 1 in 5 adults suffer from reflux disease. And hopefully this works. It's just a little video.
GERD, or Gastro Esophageal Reflux Disease, is a chronic, often progressive disease resulting from a weak lower esophageal sphincter, or LES. Also at the junction of the esophagus and stomach that functions as the body's natural barrier to reflux. Normally, the LES closes immediately after swallowing, preventing reflux. In people with GERD, the LES is weak, allowing acid and bile to reflux from the stomach into the esophagus.
I'm all about visual. Most of the time when I meet patients, an hour with folks, and most of that time is drawing pictures and trying to demonstrate the pathology. Unfortunately, a lot of the words we use get to be kind of fancy, and sometimes they cloud the whole process. So hopefully these images and some of these videos I've thrown in will at least give you a better understanding of what we're dealing with. So again, I'm not going to rehash what he's talked about. This is just to drive the point home of the many different symptoms that you can have related to reflux disease. Again, he went through, same thing, all those things that unfortunately we like to eat, drink, they do cause reflux. Anything in moderation, but unfortunately for some, even moderation doesn't work. The complications, as Dr. Bradenham went over, again, esophagitis, strictures, Barrett's esophagus, again, increasing your risk for esophageal cancer. So again, the LES, and again, we keep harping on it because it is important and it's really at the crux of the disease, okay? Normally this sits, as it says there, about 3-4 centimeters below your diaphragm. That's the normal placement for it. Pressure across that varies, but usually somewhere in that 10 to 30 range. And that's important as we get down in the surgery options, and I'll bring it to light at that point as well. The hiatal hernia that we've already alluded to, again, those two things go hand in hand, and they basically perpetuate one another and worsen your reflux, okay? Not everybody has a big hiatal hernia. They vary in size from small to really, really large. And I have a video that at least should give you a sense of what a large hiatal hernia looks like. So let's see here. So this is the video here. I won't go through the whole thing. I just want people to see the beginning part so you can appreciate what a hiatal hernia is. So again, that's stomach. This is the diaphragm, and this is the muscles, and so that's the hole for which sometimes folks' stomach, esophagus will slide up into. And I'm not going to go through the whole video because that takes too long. But that's just to give you a sense anatomically what a hiatal hernia is, okay? So what do we do once we've decided, okay, you're a candidate for potentially reflux surgery or that you really have bad reflux? We have a few tests that we have to do. Dr. Bradenham's kind enough to at least provide the endoscopy. So that's top of the list. Take a look. Again, looking for esophagitis. You can look for a hiatal hernia. You can take biopsies, especially looking for Barrett's. That's the big concern, especially if folks have been on these medicines chronically for many, many years, okay? After the endoscopy, I usually get an upper GI. So and all these studies are outpatient. So the upper GI is basically done in radiology. They give you contrast to swallow. Some of you may have had this done in the past, some may not. And then they take x-rays. And the whole point of this is to look and see the outlining of your esophagus, your stomach. They can look to see if you have a hiatal hernia. It's a better or a more objective way for me to try to measure the size of your hernia because every gastroenterologist interprets the hernia a little bit differently from small to medium to large. So I use this to objectively look at the size of your hernia. At the same time, they can change your position to look and see if you have reflux. And they'll lay you flat, prone, change things around so we can see to what level you actually have reflux. So assuming both of those show reflux, then the next two studies, manometry and 24-hour pH. Key studies, they're basically part of the gold, well, the pH study is gold standard. Unfortunately, a lot of patients, they have these studies, and I'm sure Lori was in the back can attest to it. It's not the funnest study for some patients. It does involve placing a very small, flexible tube, okay, it goes down the nose. For the manometry, it gets positioned just above, around that LES, and the whole point of that study is to look and see how well your esophagus works from top to bottom when you swallow, okay? We want to know that the food you eat, the water you drink, moves sequentially all the way through and down to the bottom. At the same time, it will measure that pressure across the lower esophageal sphincter, and that ultimately becomes important when it comes to decisions about surgery, okay? So that's the first study. Then the pH study is basically looking to objectively put a number on how bad your reflux is. It's the same thing with the tube in the nose. The difference is this usually stays in for a 24-hour period. I always tell patients it's a difficult study for some because you have to be off your meds for a period of time beforehand, okay? But the whole point of this study is basically to fail. And I tell patients this is the only test in your life you pass if you fail, okay? So ultimately, doing the things that worsen your reflux, as miserable as they may make you, may actually benefit you in the long run, because when we calculate your score at the end, it'll come out on the high side, which says, okay, you have reflux, okay? There's a minimal score. So I always tell patients 14.7 is considered the cutoff. That's basically the upper limits of normal. Any score that comes above that is considered abnormal, okay? So those 4 things I get on every patient, and each one has its own function and its own purpose, okay? And it helps put together a package to decide what's the best next step for a patient. So surgical options. It's not medicine, at least not from my side. Eventually, people wear out on the medicine and they're looking for something else, something that has some longevity, something that they don't have to remember to take every morning and be miserable. These allow you the opportunity to go back to having, in moderation, a drink, to going back to eating tomato-based things, spicy foods, sometimes the things you had to get away from, shy away from, because you're just miserable. So hopefully I can bring those things back into your daily routine. So just quickly, non-surgical, because this comes up and patients ask about it. TIF, also known as a transoral incisionless fundoplication. And it's basically like endoscopy, as you can see. It's a stapling device, and it's basically used to recreate your lower esophageal sphincter. It's something I don't do. There are folks out there that do it, so it is an option. I wouldn't say it's the best option, but it is one. The Stretta procedure, this is basically radiofrequency ablation. Again, it's done endoscopically. Tube goes down, there's a balloon, there's little metal rods or prongs that come out, and they get stuck around the level of your lower esophageal sphincter. They work by heating up the muscle and ultimately cause that muscle over time to hypertrophy and grow so that hopefully they come back together like they should be. Doesn't happen right overnight. It does take months to be effective. And again, patients usually have to stay on those PPIs for the first 3 months. And then after that, hopefully by the time we get you to 6 months, you're seeing some results from it. I know a lot of the gastroenterologists kind of look at it and some say okay, others are not big believers in it. But again, in the right patient, that may be a good option, especially somebody who's had surgery for reflux in the past, and now we're getting the second and third time around. It gets more and more complicated. So again, those are just to put out there that you're aware. So first of two, so Nissen fundoplication, okay? This has been around for at least 30 years. It's tried and true, it works, it's effective, okay? Why do we do the procedure? Ultimately to help prevent reflux and help prevent Barrett's and potentially esophageal cancer. It's an anti-reflux procedure. And again, that kind of gives you a little indication of how many port sites, okay? So there's 5 different port sites. It's done laparoscopically, it's done open. I can't say the last time I've ever done an open. Pretty much they're all done laparoscopically because it's much, much easier to do it that way, okay? Overall success rate, 95%. If you come in and tell me I've been taking Nexium for the last 5 years and it worked, and now it's just kind of lost its luster, I'm up to twice a day, kind of works, not really, that's a good sign. That means it actually was working for you. So those folks usually have a better outcome. If you tell me the medicines never worked for you, then we start looking at other possibilities. Will the surgery work? Potentially, yes. Will it have as high a success rate? Probably not. It's not going to be zero. It'll probably drop down in about mid 80% range. Overall mortality from the surgery is very, very small. Okay? People ask me about the procedure length. It varies from patient to patient. It can take anywhere as short as an hour and a half. It can take as long as 3 hours. But for the most part, I'd say 2 hours, right about in the middle. So again, why do we do the procedure? Quality of life, bottom line. Anybody who has really bad reflux can appreciate sleeping can be miserable, work can be miserable, just everyday activities can be miserable, particularly if you're not taking your meds or your meds just aren't working, okay? Again, prevent long-term use. Try to get you off your meds. One less pill you've got to remember every morning. Barrett's, we've already talked about trying to prevent that from progressing. And we've already talked a little bit about Barrett's, so I won't belabor that point. So here, the area that we're going to work on is just in, like it says, in that little box, as I just work up in that small space, right around the hiatus, right where the esophagus comes through. This is just a sense for port placement. So it's 5 different ports. All these incisions are pretty much about that big. They're less, a centimeter or less, okay? Relatively, I would say relatively painless surgery. It's more that you feel sore, not so much excruciating pain. Most do just fine within a 24 to 48 hour period. That's just a picture, small camera that we use to get inside. So again, as we go through the Nissen, hopefully these project, this is just to give you a sense of anatomy, and again, area we're working with the retractor, working up in this area here. Again, progressively, this is the opening that we're going to concentrate on here. You can see the stomach gets pulled behind the esophagus, and this kind of tube that you see in here is a sizing tube that I use. I try to use that on, I actually use that on everybody because I don't want to wrap this around too tight and cause you problems after surgery. So I use a sizing tube that gets wrapped around. You can see here it gets sutured on the front side, recreating that valve, that LES, okay? And then at the same time back here you can see the hiatal hernia, if you have it, gets closed with suture just like on the stomach. So that gives you the final product. This is just a little closer, just looking at it. Again, this is that issue, both the muscles, closing that defect and bringing the stomach around to wrap it on the front side. So again, final product, okay? So that's Nissen fundoplication. That's been around for, like I said, since 90s, 80s. And it's stood the test of time.
Dr. Smith, after the surgery,
Mm-hmm.
then are there any incidents that they have to go back again, like for the second surgery, or is it like one time it basically treats forever?
That's a good question. This surgery, one would hope that if I did it for somebody, it would last you for 50 years. I kind of look at it as like any vehicle you buy. There's some maintenance required over time. Not every car is going to run without any issues for 50 years, and the same thing holds true here. I'd say in the first 5 years, about 30% of patients that have recurrent symptoms are usually related to hiatal hernia issues, okay? I'd say in an ideal situation, you should get at least a good 15, 20 years out of it. You may find as you go along that now you'll have an occasional issue of heartburn that you need to take medicine for. Maybe not with such regularity, but just certain days you notice something and you start popping a pill. Hopefully that's the worst case scenario, but there are some patients that it gets so bad that now you start looking at having to go back and redoing surgery for those folks. Post-operatively, expectations, I tell everybody you stay in the hospital one evening and usually go home the next day. The big thing with this, compared to the other product I will talk to you about, or their option, is diet modification. Meat, bread, and carbonation, I tell everybody, do not do under any circumstances in the first 2 weeks, okay? Unfortunately, you get swelling around that area, and if you eat those things, they have such a consistency that they will get stuck. And if they get stuck, then you find yourself choking, you get spasm, you get pain, and the next thing you do is you go and you retch and you try to vomit. Vomiting, not good on that repair. We don't want you doing that right out of the gate, okay? So I really modify diets. Some people are a little more liberal. Over time, I've adjusted it, and now I pretty much keep people on clear liquids and pureed food for the first 2 weeks, okay? Most patients will lose somewhere between 8 to 10 pounds. You usually will gain it back. Some people like that. It's not a weight loss procedure by any means. However, yes, you change your diet around for a couple weeks, you will notice a difference, okay? I see patients back at the 2-week mark and the 4-week mark. At 2 weeks, if you're doing okay and no issues, then we start to advance your diet, and by that 3 week, I have folks introduce bread and meat, and by 4 weeks, hopefully you're eating the full scope of diet without any issues, okay? Exercise, I limit that for the first 4 weeks only for a chance for everything to heal and scar in place, okay? Unfortunately, there's a downside to everything, in this case, very small, but there is a downside. So complications, like I say, bleeding, infection up there, very small potential. Potential of injuring something on the inside would be the esophagus, your stomach, your spleen. There are nerves that run on the front and back side of the esophagus. All those things we take great care to avoid. Again, the risk to injuring that is very small, but again, because you're working in a small space and proximity, those things do sit there. The pneumothorax, that almost applies more to folks that have big hiatal hernias that you're having to go way up into the chest to get everything back down. So again, it's nothing that usually needs to be treated. It's usually something that happens if you injure the lining around the lung and you get gas in there, and it usually will dissipate on its own. Like everything we do, there's always a concern for cardiac events, lung problems, blood clots, but that crosses all lines of surgery, so it's not just one group, okay? The wrap itself that I showed you, can that ever slide? Yes, that can. Can a suture pull off or pulls apart? Certainly, that can happen. Can the hiatus break down? Yes, that again, also small chance. The big thing is, some patients can get dysphagia, and that's usually if that wrap is too tight. And that's why I use a sizer. I try really hard to not have that problem, and knock on wood, I have not to date. The biggest, I guess, complaint for some is the ability or inability to belch or vomit, and that's always a concern for patients. Physiologically, we were meant to belch, we were meant to vomit. It was designed that way, and so we try to do it such that you still can, but sometimes with this procedure that can happen, okay? Gas bloat, I put down there about 20% of patients can experience that. This is basically where you eat and then you feel like a big balloon inside your stomach. It does go away as you digest the food, but again, it's very uncomfortable. If you've ever had bloating, for some people who've had gallbladder issues, it's miserable. So that's probably the one real downside to this procedure. It's a great procedure, don't get me wrong. I've done it, again, for many years, and it's done really well for patients. So I just want patients to be aware of all the upsides and all the potential downsides. So again, as we talked, overall you can expect a good 95% success, and then again, usually issues that creep up in the first 5 years, as we talked, are hernia related. So I'm going to change gears. So this is a product that has been around for a while but wasn't approved by the FDA until about 2012. There have been pilot trials and other things done for the last 9 to 10 years, and conveniently, and one of the reps from the company was kind enough to come today and at least provide some of the brochures for me. So some of these videos, just to let you know, I've gotten off of their website just so that I can share them with you today. So we'll go through this procedure here as well. I have an actual device on the table if anybody wants to see it afterwards. Sometimes it's nice to be able to hold it. It's very small. but you can certainly look at it outside. So, all right, so LINX procedure. So this is the device. So these are, again, magnetized beads, okay? And you can see titanium casing, and again, the metal wiring or titanium wire in between. And it comes, again, it looks like a little bracelet, okay? Or at least when you put it together. Otherwise, it comes as a string, just like a bracelet, and gets wrapped and hooked together by magnets. Ultimately, this device is placed similarly in the sense, still 5 incisions. I don't change the incisions, just like the Nissen, same 5. The only difference is that I don't do all that you saw where we take down stomach, we wrap the stomach, we do all that suturing. I don't necessarily do that with this. This is much more minimally invasive, okay? You're just dissecting basically behind the esophagus. As you can see, the bracelet comes around, gets hooked on the front side, and then ultimately shows you someone who's able to swallow with it in place. So overall, worldwide, thousands of devices have been placed to date, okay? Again, as I told you already, the experience over the last 9 to 10 years, and again, it's been around and approved since 2012. Big things just to keep in mind, because patients always ask about this. Okay, we got this foreign body that you're putting in. What can happen with that? Well, to date, all the studies have shown the overall erosion rate is extremely small, okay? And of those that have occurred, they've all been treated basically in a non-emergent fashion. So either they've been removed endoscopically, or they've been removed laparoscopically, so surgically. And there haven't been any long-term sequelae from that, okay? The device removal rate across the board is probably less than 3%, okay, for all the people that have it in. There's going to be some it doesn't work for a variety of reasons we'll talk about, so less than 3%. It kind of talks here, again, safe, simple, and again, preservation of anatomy. There is no disrupting the normal anatomy. So again, setup is similar to Nissen fundoplication. Again, I usually say patients stay overnight. You can go home, but for the most part, at least one night in the hospital. The biggest difference gets into these last 3, or this point here, and a few others to follow, diet-wise. Normal diet post-op, okay? There's no liquids, there's no pureed, there's no weight loss. You basically start back on a normal diet the next day. And the whole point is, as you can see when you look at the device, it moves in and out. It's like a spring. And ultimately, you want to train that spring. So by eating, it causes it to move in and out. So as it scars in over those first couple weeks, it scars in with room to move. You just don't want it to sit there stagnant and not do anything, because that's how it'll scar in. And then its overall functionality goes down. And then you have certainly concerns for what we talked about, erosion in the long term. Activity, they say you can resume light activity. Again, that's you know, subjective in terms of what you do, but you can go back to doing some form of exercise. MRIs, again, another concern for many people, have to have MRIs of back, whatever the case may be. There is a limit, but yes, you can get MRIs, and it's just something you need to talk to your radiologist or physician about should you need one, okay?
What if you go on an airplane and you have to go through all those scans and things?
There's a card. You get issued a card just like you do when you have certain procedures, and you carry the card, and you basically, they'll ask you, do you have any metal in you? And you say yes, and you show them the card, and that should hopefully alleviate any issues, unless you have one of those hostile TSA people, but hopefully not. You should not have a problem. So real contraindications, they're not a lot. If you're allergic to metals, titanium, nickel, okay, probably not a product for you. If you just outright don't want anything foreign inside your body, then again, probably not a good idea, okay? Other things that they've looked at, there are people that are kind of working with this at larger centers. Right now I'm sort of adhering to the letters of the law. So hiatal hernias, so folks that have small hiatal hernias, okay, so less than 3 centimeters. And actually that should have been flipped the other way, not greater, but less than 3 centimeters. Or I should say contraindication, anything over, ideally we want you less than 3. Barrett's esophagus, if you have really, really bad esophagitis, Age right now, anyone under 21 years of age, it's not recommended. And then also folks who have BMIs over 35, okay? Long-term complications, I've already talked a little bit about erosion, and then dysphagia, meaning difficulty swallowing. There is a honeymoon period, the first week, 10 days, that folks do just great, and then all of a sudden they start to notice these issues with swallowing. It's usually short-lived over the next week or so, and we try to weather that storm with medications and diet modification if need be. And most get through it and do fine. There are those that if it gets to be chronic and long-term, then you have to look at taking the device out. And like I said, it's about less than 3% across the board. Comparatively, I'd say 85, close to 90% of patients with this do just fine and have great relief, just like you do with the Nissen fundoplication. It definitely helps with regurg, very high. I mean, not 100%, but pretty darn close, okay? Again, overall heartburn is reduced down to about 11, 12%. And then the most important thing is quality of life. And that's honestly my goal for doing this surgery, is to improve people's quality of life, to get you off your meds, to allow you to go back to doing the things you want to do, and allow you to eat the things that you want to eat. So when you look at it, inherent differences, one's creating a sphincter. Okay, so basically this creates a new sphincter, a one-way valve. That one is augmenting that lower esophageal sphincter. I'm not creating a new one, I'm just trying to give it some strength. The beauty is that we add some strength to it, but you can get enough pressure in your stomach that at least you can overcome that. And like I said, you can belch and you can vomit if you need to. Again, the one-way valve. This one, obviously we talked, disrupts anatomy. The other one ideally preserves anatomy. Physiology, that's important. This is not necessarily physiologic, okay? Like I said, everybody has some reflux. It's normal. Again, it's a release valve. The other side does allow you to maintain that. So that's the upside. It's my throw-in for politics these days. The one thing that I want to at least mention, like anything that's new, insurance companies are the bane of our existence. Okay, so LINX is by all rights new, and so trying to route that through insurances, I can almost tell you 100% the first go around they're going to go, yeah, no, we're going to decline that. That doesn't mean that it stops there. There are several tiers that it goes through. The biggest thing you just need to be aware of, those tiers take time. Okay, it's not going to happen in a week. It's probably not going to happen in a month. It can take several months. Anywhere 3 months, maybe 5 months, depending on the insurance company. Next year, they're looking at recoding the procedure, so hopefully that will give us a little latitude and help out with trying to push some of these things through. If it's something you're definitely interested in and you want to do, I encourage you, if you're willing to be patient and your meds work, I think it's worth pursuing. I was just at a LINX conference last weekend in Chicago with a whole host of surgeons that are doing this, and I think the general consensus out of that was, in time you will see this device slowly start to replace Nissen fundoplication as first-line treatment. The beauty is that the device can be removed if for some reason, again, you have issues. Like I said, it can be taken out laparoscopically, and you can still do a Nissen fundoplication for a patient. You don't burn a bridge. It's just, again, if it doesn't work for you, that is a potential option, okay? I think that's all I can say about both of those at this point. Obviously, if you all have questions, myself, Dr. Bradenham, are happy to answer those in any capacity, as a group, offline. I'll stick around for anybody. Like I said, the little LINX device I brought, it was sitting out on the table. You're welcome to at least see it, play with it. You can see what it looks like. Again, it's about the size of a quarter, so it's pretty small. So hopefully you all got something out of this. I know they gave you sheets to fill out. If it was helpful, please, if you could at least make a comment that it was, or if there's something we could add or do differently. we'd appreciate that feedback because, again, we're trying to build this program more and more as the years go